It's probably one of the most commonest non-traumatic painful condition of the hand. And in my practice, I have probably diagnosed diabetes more often in a patient who has come asymptomatic for anything, just on the fact that he has a trigger finger. So he doesn't have any inkling or any knowledge about diabetes. And the patient comes with a trigger finger, and you just ask him whether he has done his sugar levels and all that. And then when you take, or before you take the patient for surgery, you are surprised by the levels of blood sugar. So be very careful in operating a trigger finger without confirming his diabetes level or sugar levels. The presentation of a trigger finger uh, in practice can be from just a painful movements of the finger, or else most of the time they don't come to you for pain, they don't come to you for this first symptom which I've written on the slide. They always come for triggering or snapping, which is all accompanied by pain. Most of the patients, they tend to neglect it. They go to take some medicines. Most of them go to physiotherapists on their own, and they put their hand in paraffin wax baths, which aggravates the matter further. Ideally, you should rest the hand and you should apply ice, which the previous speaker has mentioned, but it is not unfortunately done. And then they come with the last two symptoms of either inability to extend or inability to flex actively. And then the hand looks like this. Either the patient cannot flex the finger or he cannot extend the finger. This condition or this appearance is a sort of an emergency. I have had doctors who have been taking treatment with me, who have been postponing their surgery or postponing their treatment and not or neglecting their hands, and they come one day morning with this, I'm not able to open my finger, how can I operate? So I operated this doctor as an emergency case for a finger which had got stuck and is very difficult. So basically, a finger which has to be opened passively or the finger which does not open up is an emergency, or it has to be done by it has to be treated by surgical means only. Basically, in my opinion, the surgery is so simple that it cannot be simpler than a percutaneous surgery. So the surgery is so simple that you can do it. Just such a small incision is generally required. The anesthesia, I prefer local anesthesia with sedation, because sometimes I feel that a patient can tolerate a tourniquet much better with a sedation. And but tourniquet is a must. You must have a bloodless field, because the nerves, as you know, you have to take care of the digital nerves. It is unpardonable if you cut the digital nerve during this surgery. Now I will be showing some steps of the surgery for trigger finger. In this case, where all the four fingers were involved, and at that time I didn't know that Sanjay would invite me for this lecture. So photographs have been taken at various stages of this operation. So I will use those photographs to demonstrate or highlight the points. So in this case, all the four fingers were involved. The patient had inability to extend the little finger and ring finger, and painful range of motion in the middle finger and index finger. That is the incision that we take as a standard transverse incision, which is about 5 to 8 millimeters distal to the distal palmar crease. And obviously, all these cases are done under tourniquet and under sedation or this thing. So that is assumed. And the main thing to remember is that once you cut the skin and you start seeing the fat, the moment you see the fat, you stop. You don't take the knife beyond the fat. And then that's the thin layer of fat that you see. The important thing after this step is to dissect in the midline. Dissect in the midline of the finger. And that is the place where there is a tendon. The tendon, remember that the tendon is a deeper structure in the hand as compared to the nerve. The digital nerve is superficial to the tendon, but it lies on the sides of the midline of the finger. So in that way you can be very safe. Once you see the fat, you go in the midline and then do a vertical dissection. don't dissect transversely, do a vertical dissection and then go transversely. And this is a slide. This is not a case of trigger finger, just to demonstrate or highlight the fact that a digital nerve lies on the side of the tendon and it is superficial to the tendon. So please remember that. And when you have an assistant, the assistant generally starts taking a retractor and pulls on either side of the incision. The incision is so small that you want to be very careful that you are dealing with the tendon or the A2 pulley, A1 pulley, and you are safeguarding the nerve. So keep the right angle retractors at right angles to each other, because your forceps will work as a third retractor. And your hand is using an artery forceps or scissors, and you can just go up to the tendon and cut the A2 pulley. So the retractors have to be at right angles to each other. And then you identify this A2 pulley, you identify the A1 pulley, and if possible, because then if you can insert a mosquito forceps here, that means that the pulley is quite pliable. Many times this is not the case. You will have to use a forceps, just lift it up and gently cut on the side of this with a blade, 15 number blade. And so identify the A1 pulley, and then you incise the A1 pulley with a scissors and confirm that this pulley is completely released. Sometimes you may have to release the proximal part of the A2 pulley also. How do you determine whether the release is complete? You can, in addition to the tendon, you can also insert a mosquito forceps inside and just see if there is adequate space in the A2 pulley or the beginning of the A2 pulley, so that both the tendons are going there and the mosquito forceps also goes into the pulley, and just open it up slightly. That means there is adequate space in this A2 pulley, and that is not going to be the source of constriction further. Because what happens is, many times patient comes so late for the surgery that they have developed tenosynovitis, they have developed inflammatory changes along the tendon. So you have to be very sure that not only the A1, but even the whole track of the tendon is free. So incise the A1 pulley and then expose the tendons and make sure that there is no, many times you see a small ganglion or something, other things also on the flexor tendons. So that is the, and very important thing, this is the step for the surgery that you require that sedation for. Of course, you require sedation for the patient to tolerate that tourniquet also, but you mobilize each individual tendon. You mobilize the sublimis tendon and you mobilize the profundus tendon and make sure that they are free of each other. Because of the chronic or long-standing disease process, many times patient post-operatively, I have seen that they don't get complete relief or complete free movements or painless movements if these two tendons are not mobilized separately and they are not freed from each other. So you excise and clear off all the inflamed tenosynovium, if any, from the tendons. I always like to use a 4-0 or a 5-0 suture material for suturing the skin. Sometimes I use horizontal mattress sutures also, but many times these interrupted sutures are enough. But if a thin suture material used, there is no post-operative keloid or any tenderness along the scar. Of course, you give a compression bandage to the patient and mobilize them immediately. The secret or the message post-operatively is that you mobilize actively, completely. Full extension and full flexion of the fingers must be insisted before you discharge the patient, and mobilize immediately and actively all these patients. Many times patient will develop post-operative adhesions, and for which you massage the scar, you give them gripping exercises. Many times even that does not help, so you have to use this Kapner splint that helps to relieve the post-operative adhesions and get the full extension to the finger. And of course, patient has to actively flex the finger. A trigger thumb is same as the thing, only there is a single tendon you have to deal with. The only problem is that the nerve is much more closer to the tendon, and the lateral nerve, the lateral digital nerve, is much more superficial and at an oblique angle to the flexor pollicis longus. So be careful about the lateral digital nerve. This is a case, this is only a dissection diagram. This is not a case of trigger thumb. Then again you have to mobilize. In this case, there was a small ganglion which was arising from the flexor pollicis longus. So that we could identify, because I lifted up the tendon, wanted to free it, I saw this ganglion in this case. Probably a differential diagnosis is you have to be very careful of an inflammatory flexor tenosynovitis. Like this, the patient presented with a boggy swelling in the palm along the line of the index finger, but on careful examination, we know that this is not a case of trigger finger, this is a case of flexor tenosynovitis. So this case, though the patient may have triggering, but clinically the swelling extends from here to here, and the patient has painful movements. So this is not a case of trigger finger. So this has got to be explored under formal anesthesia, and you explore the sheath, identify the tenosynovium, excise it, preserve the pulleys, and then proceed further. I thank you all for your attention.